Good morning, everybody. Today, Harish will be presenting the case. It will be moderated by Professor Kishore and Professor Sharvari Pujari, and Professor Sadiq might be joining us shortly. So in the meantime, we can start off. Kishore and Sharvari can take over now.
Good morning, sir.
Good morning. Please start.
Sir, can I start, sir?
Yeah.
Yes, you can start.
Yes, thank you. My patient is a 27-year-old male who is student and is a resident of West Bengal. And his chief complaints were yellowish discoloration of eyes and urine since last 1 month. He was apparently all right 1 month back, and he noticed yellowish discoloration of eyes and urine, which gradually progressive and painless in nature. It was associated with generalized itching, which was associated with sleep disturbance since last 2 weeks, and it has also associated with passing pale colored stools from the last 2 weeks. He has no history of prodromal symptoms, fever, malaise, joint pain, and he has no history of abdominal pain, vomiting, and there was no history of waxing and waning of jaundice or passage of silvery stools, and there was no history of loss of weight, loss of appetite. And he didn't give complaints of any history of altered bowel habits. There was no history of any other drug abuse or alternative medication intake for long duration, and no history of hematemesis, melena, postural dizziness, syncope, fatigue, or shortness of breath, and need of any blood transfusion in the past. No history of respiratory discomfort, hemoptysis, bony pain, or backache. No history of recent onset of diabetes, or no history of any TB contact or chronic cough. He was evaluated elsewhere with MRI and referred to tertiary care center for further management. And no intervention was done elsewhere. In his past history, there was no medical comorbidities and no history of any surgical intervention. And he had no significant family history. His sleep is disturbed, appetite is normal, bowel and bladder habits are normal and regular, and mixed diet and no addictions. Summary: 27-year male with no significant personal, past, and family history complains of painless progressive obstructive jaundice with troublesome pruritus without any other significant clinical history or cholangitis episodes. My provisional diagnosis is benign biliary stricture. Possible etiology is primary sclerosing cholangitis or stricture in choledochal cyst, or TB lymphadenopathy is compressing obstruction of the CBD. And remote possibilities, familial adenocarcinoma of pancreas.
Okay.
Hello.
Yeah.
Yes,
Good
sir.
morning.
Please.
Yeah, Dr. Sharvari, you go first. I'll ask after that.
Okay. So I just wanted to ask you why these are your diagnosis and still what are your concerns? Because you said pancreas also once and benign biliary stricture also once. That is why I'm asking.
Yes, ma'am. Ma'am, young patient with only history of painless progressive jaundice without any symptoms of loss of appetite, loss of weight, and any family history of malignancy. I was thinking of benign etiology, ma'am. But he doesn't have any cluster of symptoms to point out any particular benign etiology with the only complaints of obstructive jaundice in young age, ma'am. So I was thinking of remote possibility of familial malignancy as an index case in this patient.
Okay. And you said pancreas also something. What was the last differential diagnosis?
Familial adenocarcinoma of pancreas, ma'am. Being he is the index case.
Familial adenocarcinoma of pancreas. Is there something, some terminology like this?
No, ma'am. There are carcinomas which are associated with this one.
With
Familial syndromes which are associated with pancreatic adenocarcinoma. That I want.
Okay. But is there any history of pain or something which leads you to think about this pancreas?
No, ma'am. He didn't give any history of pain.
Okay. So
But I
you
just
okay.
want to rule out possibility of malignancy in this patient.
Okay. So, sir, Dr. Kishore wanted to ask something.
Yes,
Yeah, so Dr. Harish,
yes, sir.
what is very unusual in this presentation? Normally
Sir.
you take a history.
Yes, sir.
So what is striking in this history, unusual from what you normally see?
Sir, he is engaged with only complaints of painless obstructive jaundice without any constitutional
Correct.
symptoms either fit into benign or fit into malignancy, sir.
Right. Suppose if it were instead of 27, if it were 67,
Yes, sir.
it will be very easy for all of us. So
Yes.
you say painless progressive jaundice in an elderly person who is, 65, 70, you would think of malignancy first. But the striking, unusual thing in the history is that it's a very young person.
Yes, sir.
Now, apart from that, if you look, you have to just analyze your history. Don't try to fit in things, because in your differentials, you're giving a lot of pathological diagnosis also. Choledochal cyst with a stricture, TB lymphadenitis causing extrinsic compression, then a pancreatic malignancy. So all these are pathological diagnoses, which is extremely unusual to pick up from a atypical history.
Yes,
So
sir.
what you should say what you feel, at this level. So you should say that it is a young person with a painless progressive jaundice. You can't say TB because generally TB to involve the liver or the biliary system, usually there will be other symptoms. Patient will have florid TB or he'll be treated with ATT and then later there's a biliary stricture developing. All right. So primary sclerosing cholangitis you can think of, but again, it will not be a first presentation. Usually there will be a long history with, recurrent episodes of pain, cholangitis. There will be visits to a medical facility at some point in time. And familial pancreatic adenocarcinoma, again, you shouldn't venture that out as your first diagnosis. I mean, as your differential. So I think you will be okay to analyze here and say that it is a very short history of about a month of painless progressive jaundice. Normally, I would have thought of malignancy, but then since the age is so less, I mean, it strikes me as a very unusual and atypical finding. So you don't have to come to your differential diagnosis immediately after history, but you should have some possibilities in mind and what you want to do next. All right. And what do you think about this history of bone pain and and the other features of liver failure that are mentioned, with hematemesis, altered sensorium? Do you think all that is relevant in this case?
No, sir. Such a short history, it is not, sir.
So see, in this sort of format where you're given a case history, you may take a history on your own, but here you're also expected to interpret what you think of what is given. So if you see the negative history that is given, it is too extensive. It may not be relevant here. History is pertaining to liver failure may not be relevant here. That happens in chronic liver disease and decompensation. So you should also analyze what you think it is. Okay, I would think that would be the way. And here, I think you should say that it is a very unusual presentation. I'm not sure if it is malignant, but I would like to, examine further and investigate before I come to a conclusion. That may be fair, I think. And may I request Rabella sir or Pradeep sir or any of the seniors to sort of chip in at this time before we go on to the examination?
No, we can have at the end this thing.
All right. Please go on to the examination.
In his general physical examination, he is well-oriented to time place. He is well-oriented to time place person, and he is cooperative. And his BMI was 21.8 kg per meter square. He is moderately built and well-nourished with ECOG of 1. His breath holding time is 30 seconds. And icterus is present with no pallor, cyanosis, clubbing, lymphadenopathy, or enlarged left supraclavicular lymph nodes, or any peripheral edema. His pulse rate is 90 per minute with BP of 110 by 70 mmHg. Respiratory rate is 16 and febrile with saturation of 98% at room air. In his per abdominal examination, inspection was normal. There was no significant findings. Abdomen is flat, umbilicus central in position with inverted. All quadrants move correspondingly with respiration. No visible scars, peristalsis, sinuses, engorged veins. scratch marks are present, hernial orifices and external genitalia appear normal, bilateral renal angles appears normal. On palpation, abdomen is soft and non-tender, liver and spleen are not palpable, soft, non-tender, globular, 3 into 3 cm swelling with smooth surface and round margins palpable just below the costal margin, moving with respiration, suggestive of distended gallbladder. Hernial orifices and external genitalia are normal. Liver dullness upward palpable in 5th intercostal space in right midclavicular line. Liver's plan is about 13 cm in right midclavicular line. Flanks are tympanic. On auscultation, normal bowel sounds heard. Digital rectal examination, normal sphincter tone, glows stained with grayish color stools, no palpable growth or pelvic deposits. His other systemic examination was within normal limits. Coming to summary, 27-year male with no significant personal, past, and family history complains of painless, progressive obstructive jaundice with troublesome pruritus without any significant other clinical history or cholangitic episodes. On examination, icterus was present with ECOG of 1, with soft, palpable gallbladder on per-abdominal examination and clay-colored stools on per-rectal examination, and no other significant findings on other examination findings. So, provisional diagnosis, benign biliary strictures.
What other finding you've got extra on examination now, which is significant?
It is the obstruction is at the level of GB neck or below it, suggestive of that thing.
All right. So you've got a palpable gallbladder. That is the important finding you've got.
Yes.
And based on that, how would you what would you think? What are the possible diagnoses that you have? You have a differential list now.
I would still think
you want
of
to change the order, or you have something else you want to add on? Or what do you think?
I would still like to keep the same things up. I will think of still benign biliary stricture in the distal CBD.
All right. Okay. So why can't it be a malignancy?
Harish,
Yes, ma'am.
I again wanted to ask you why you have included pancreatic malignancy. The pancreatic malignancy, you are talking about periampullary or head of pancreas you are thinking of, and what will be the presentation of that? Benign biliary stricture I accept. Second diagnosis would be a malignant biliary, distal biliary stricture, isn't it? Why pancreatic malignancy?
In pancreatic malignancy, especially which comes under periampullary variant, ma'am, because it is associated with family
so
history.
you want to include periampullary malignancy, not pancreatic malignancy, right?
Yes, ma'am.
There is a difference in periampullary and pancreatic. When you call pancreatic, it appears as if you are talking about CA head of pancreas. So what do you want to include here in differential diagnosis?
Periampullary.
Okay. So how many percentage of periampullary? So it is definitely not head of pancreas, right? Head of pancreas would present, what will be the presentation of head of pancreas?
Pain and obstructive jaundice. With
Okay, so basically here it is a painless jaundice, right?
Yes.
Okay, and what will be the presentation of periampullary?
Painless progressive jaundice with chances of melena.
Okay, so maybe waxing and waning of jaundice, it may or may not present.
Yes.
Okay, so what comes in periampullary malignancy? What all things come in periampullary malignancy?
Any lesion which is around 2 cm from the papilla, that is distal cholangiocarcinoma, pancreatic head carcinoma, duodenal carcinoma, or ampullary carcinoma. 4 variants.
Okay, so which will be most likely in this case you feel, or otherwise also which is the most?
Distal cholangio is most likely.
Okay. Now second thing, second thing is you included first diagnosis as primary sclerosing cholangitis. So
Yes, ma'am.
is there any history suggestive of cholangitic episodes?
No, ma'am. There was no history of any cholangitic episodes in the past.
Okay. So, so you feel the painless progressive jaundice without cholangitis will be the presenting feature of primary sclerosing cholangitis?
No, ma'am. In classical history, patient will be having features of IBD along with chronic indolent course of jaundice, ma'am. Not sudden onset progressive to this extent, ma'am.
Presence of IBD is mandatory. How many patients of IBD have PSC and how many patients of PSC have IBD?
Approximately 70 to 80% of PSC patients will have IBD, and approximately 10% of patients with IBD may have PSC, ma'am.
Exactly. So IBD is all IBD patients won't have PSC. So IBD is not a mandatory for having PSC. Anyway,
Yes.
so still PSC will be the first diagnosis in first differential in benign biliary strictures in this case.
Ma'am, because engaged without any history of any surgical intervention in the past, I was thinking of this possibility.
Okay. What all are the other possibilities of benign distal biliary stricture? More common things.
In general scenario, more common in the most common is iatrogenic. Second will be chronic calcific pancreatitis leading to obstruction of distal CBD, ma'am.
Right.
But in this case, these two were less likely, ma'am. That's why I kept PSC.
Yes, good. And something uncommon but may be seen in this young age because patient is young.
I'm not getting that, ma'am.
Autoimmune.
Autoimmune is a possibility, ma'am, but autoimmune, especially IgG4 cholangiopathy, presents at later 5th to 7th decade, along with
Oh,
history of other autoimmune manifestations.
okay, that is why you are thinking of PSC as a first diagnosis.
Yes, ma'am.
See, I think, Harish, still, I wouldn't really agree with your first, the order of differential diagnosis, because you kept both benign and malignant. First is benign, second is malignant. And the benign possibilities which you have kept do not fit into your history. You should not try to fit in just because you have atypical symptoms. You
Yes.
should keep your possibilities open, because from the history and examination, you still don't have enough information. I think I still stand by that. After your history and examination, the only extra finding is a palpable gallbladder, which gives you a sort of indirect clue to the level of obstruction. It doesn't change your etiology or pathological diagnosis. From history and examination, you can just make out that probably the level of obstruction is below the cystic duct,
Yes.
or even if it is higher up, the cystic duct is also involved in the obstruction. Isn't it? That's all you can make out.
Yes.
So you just know that there is an obstruction somewhere in the biliary system, which is involving the cystic duct. That's all you can make out. With that, you can keep your possibilities very broad, and then you can interpret what are the possibilities. I would still think that because of the age, you're thinking more in terms of a benign pathology. So you would think any of the malignant masquerades are a possibility. All right. So that is a huge list, and you can rule out certain things like infections. You will rule out TB and HIV infection also from history. And history of TB, you should specifically ask in the patient, and past history in the family. Was there any family history? So you rule out infections. Autoimmune conditions also, you can ask some history to see if there are joint pains, if there are other systemic involvement. Then you should always remember that apart from this, there is some, there is always a possibility of malignancy. Even in the malignant masquerades, only 10% will be benign and 90% will still be malignant, or at least more than 2/3 will be malignant. So you should think that I will always keep the unusual possibility that it is malignant. I think you should approach it in a sort of syndromic way. You'll see what are the possibilities. So differentials, I would say that, I mean, this is a very unusual presentation. He's a young man with, apart from the age, the other things seem to be pointing towards the malignancy. But I entirely don't want to rule out a benign cause. And so I want to keep in mind certain malignant masquerades. And I will go the extra length to ask in history which all I can rule out. Instead of saying the difference like PSC, CDC, TB lymphadenopathy, you should lay emphasis on the negative history that will rule out these things, rule out infections, rule out autoimmune conditions, rule out rare systemic disorders, and then say, okay, this is the possibility. All right.
Yes.
Okay, so now you have a history and examination. If you were to do blood tests, what blood tests you would do and what imaging you would do for starters. If he has come to your OPD, this is the first presentation. Just 2-3 tests which you have to do, blood tests and imaging what you would do.
In blood test, I would like to do his CBC, LFT, coagulation profile, and renal profiles.
And imaging wise?
And imaging wise, I would like to get ultrasound first, sir.
Okay. Can we please see the reports? You can just go ahead and interpret the LFT and say what you feel about it.
He has normal levels of albumin with along with raised bilirubin and ALP suggestive of obstructive jaundice with near normal SGOT and SGPT, sir. And coagulation profile is normal, sir.
What is your interpretation of this? What is your interpretation of that, Dr. Harish? I think we lost you in between for a second.
Sir.
Okay.
LFT was suggestive of obstructive jaundice with bilirubin of 20 and his albumin is within normal limits with normal coagulation profiles.
So you can say that the synthetic function is preserved.
Yes.
There is no evidence of cholangitis, which corroborates with the clinical presentation. And there is deep jaundice. It suggests of obstruction.
Yes. And his CBP is within normal limits. No evidence of increased TLCs, infection.
Again, you can say it's probably mildly elevated. I don't know what is the normal level in the lab, but it's probably you can say it's normal. And you can say there is no evidence of chronic liver disease again. Your platelet counts are normal. Okay.
And his RFT is within normal limits.
How will this help you?
In terms of one is there any history of like renal compromise to manage it because of dehydration component? One is management purpose, and second thing is to get if there is requirement of any contrast enhanced imaging, it will help, sir.
Okay, that's good. So you want to do a contrast imaging, and you know that there is no cholangitis or AKI. All right. Any other blood tests you want to do?
I want to get like IgG profile and tumor markers, but not at this stage.
Okay. Tumor markers, what would you want to do?
CEA and CN 19.9, sir.
Okay. Do we have that also? CA 99, CA?
CA 19.9 is highly elevated, sir. It is 10,000, but with obstruction, with high jaundice, sir. We have to keep it.
What is your interpretation of this?
It is highly elevated in the background of jaundice, sir. So
you should probably say that it is still disproportionately elevated, isn't it?
Yes.
Even at the bilirubin of 20, if you see 10,000, you would probably be concerned that it's a malignancy, isn't it? But I understand in obstructive jaundice, you have to interpret it with caution, but 10,000 is significantly high, isn't it? Okay. Ultrasound can please. So just take about half a minute to read through the ultrasound and just tell us how you would interpret this ultrasound.
yes. In ultrasound, it is suggestive of there is a mass in the conflict involving the porta hepatis that is approximately 5 into 2 centimeters, and gallbladder is grossly distended, and liver is normal in size and contour, but there is hyperechoic patchy areas in right lobe and more bilateral IHBRD in the left lobe, sir.
You
And
shouldn't
no
read
evidence of
what is there.
metastasis.
See, you don't read what is there. So you just interpret it first. What is your
Hilar
thought?
mass is hilar mass with evidence of bilateral IHB obstruction, both lobe obstruction, not extension into the CHT, with no evidence of meds.
Okay. Was it
Okay,
something
so
that you
now,
expected?
yes, so sir is asking, was this your expectation, according to your expectation?
I didn't get.
So,
Hello, Harish.
are you surprised at the ultrasound finding, or this is something that you were expecting?
Hello.
Was it something you expected, or is it a surprise finding for you?
I was expecting below 60 ducts, but it found out to be above the 60 ducts, probably in the 60 ducts.
Also, you
So
were not
now, how
expecting
can
a
you
mass, isn't
explain?
it?
How will you explain this at mass at porta and gallbladder is distended and palpable also clinically? Now, what can be the possibilities? Now, what will be the change in differential diagnosis?
Now, probably malignancy possibilities little more higher up, ma'am. But there is no regional lymphadenopathy also they have mentioned, even though ultrasound is less sensitive. But still, I would think of like benign etiology with
No,
mass.
whether it is benign or malignancy is one thing, and the
Yes,
level of
ma'am.
obstruction is one thing.
Yes, ma'am.
Right. So initially we were thinking that a level of obstruction is in the periampullary or distal CBD region. Now, what is the level of obstruction and why there is gallbladder dilatation also?
Yes, ma'am.
So on ultrasound, see how you should say is, there is an obstruction, first of all, right? So there is clear obstruction because there is bilateral IHBRD. The level of obstruction they have clearly mentioned is somewhere at the hilum. So there is, the level of obstruction. The caveat is gallbladder is also distended, but like I said, probably the cystic duct is involved in the obstruction that they can't see. Then the reason for obstruction also they have mentioned, it's a hilar mass. It's clearly mentioned. So we don't know whether it's benign or malignant, like Madam said, at this point. Then other supporting features, there is nothing, if it is malignant, there is nothing to suggest distant spread. There is no liver lesions, there is no cholangitic abscesses, there is no gross lymphadenopathy, there is no ascites. So that's how you interpret it. All right. So what do you want to do next now?
In this case, I would like to get CECT, sir. And he had a history of getting MRI done elsewhere else, so I want to evaluate that also, sir.
So don't you want to see the MRI first?
Malignancy, yes, sir. I want to see MRI elsewhere done outside, so I want to see that
So if
first.
it is there, can you see that? That will give you some more information, then you can do what you have to do with it. What do you see?
Yes, there is no falsification of primary hilum. Primary hilum is blocked, sir. And secondary hilum confluence on right and left are formed, not involved. And distal CBD is visualized, sir. And
No,
no
you
issue.
take the right anterior and posterior are joining together to form a common duct. Is that what you're saying?
Yes, probably, but not evident, sir.
No, you have to see
Right
say
posterior.
what you see.
Okay, sir. Right secondary confluence is also not formed, sir, in this.
Yeah, you have to say it. It's very clear, isn't it? All the ducts are separated. Right anterior, right posterior, segment 4, 2, 3. Everything is separated. At least on the pictures that we are seeing on the left, it looks like that. What else are you seeing?
On left side, I still like, I think it is not involved. Secondary confluence not in.
Okay, maybe yes. On the left side, at least 4 and 2, 3 seem to be joining together on the left upper panel.
Yes.
But right side, everything is separated, isn't it?
Yes.
And what else are you seeing? You're seeing a hugely distended gallbladder.
Usually it's in gallbladder.
That's all you can see in this, isn't it? So what do you want to do after this?
I would like to get CCT abdomen
Yeah.
and
So
chest, pelvis.
CCT abdomen.
Abdomen, chest, and pelvis.
Means
And
what? Means why? Now, what is your diagnosis? Your diagnosis has to keep changing or evolving so that you are asking for the next investigation, right?
yes,
So now, what do you think? What is this lesion?
ma'am, my benign possibilities less likely, ma'am, in this patient. Whatever benign possibility I had kept, they are less likely with this MRI imaging, and it probably hilar cholangiocarcinoma.
See,
Hello.
Okay. Again, I'm telling you, benign or malignancy is the last thing that will come, right? So you can say that the level of obstruction is near the hilum. There is a stricture or the mass lesion, because here it is seen all the ducts are separated. Either something from inside or outside is compressing. So now you want to evaluate the lesion, right? So you want the
Yes.
next investigation.
what do you think are the common causes of hilar block?
Common causes will be malignancy first, sir.
Can you list out 3 common causes of hilar block?
Yes, sir. Malignancy and iatrogenic injury high up in the CHT, extending into the confluence, and any mass forming benign cholangiopathies, IgG4 cholangiopathies.
All right. I mean, I'll agree to largely what you said, but
And
see, you should think
CAGB neck also, sir.
correct. I was expecting you would say that. See, CA hilar cholangiocarcinoma is a possibility. CAGB neck infiltrating into the hilum is a second possibility. Then rarely, if you hear there is no history, but Mirizi and other things are also important. Here you're seeing a mass forming lesion there in the
Yes, sir.
hilum. So I would still think hilar cholangiocarcinoma, a CAGB neck, you have to see properly in the imaging, CAGB neck involving the hilum, or any of the malignant masquerades which are presenting as a hilar mass. So this would be your thought process at this point. Then I would think that, yes, I agree with whatever you said. You want to do a cross-sectional imaging. Again, I would say that if this person has had a proper MR outside, you would review the CD and see if there is already a contrast MR done or not. If it is not done, you can go according to your institutional preference, either do a contrast enhanced MR or a contrast enhanced CT. Here we'll agree, okay, you're doing a contrast enhanced CT. You would want to do a triple phase imaging because you want to see the arterial phase and the portal phase and a delayed phase nicely to pick up one, the enhancement characteristics of the lesion, and also the vascular anatomy, which you want to see in detail. Okay. Okay, so shall we see the imaging if we have any cross-sectional imaging? Okay, while we're waiting for the imaging, what is your priority at this point in time in terms of patient planning? You would want to see the images for sure.
Yes, sir.
Yeah, okay. Please interpret the images.
It is taking time.
Okay, you can keep talking. What do you see in the plain scan?
I'm looking for any possibility of calcification elsewhere and any like gross liver lesions which are appear. And I can see only block and the IHBRD in this thing, sir. Other than that, nothing. No free fluid also, sir.
Yeah. Although IHBRD is best commented on a venous phase, it's
Yes.
obvious here you have gross IHBRD, you have a grossly distended gallbladder. So these are two things that are obvious and striking. So you have to mention that. And you should also assess the general contour of the liver to see if there's any CLD, although we are not expecting in this case. Splenomegaly, things like that.
In arterial field, lung fields appears normal, sir. And the right hepatic artery is probably encased. Right hepatic artery is encased by the tumor, sir. But
No,
there is no counter change in it, sir.
no. You should first show the tumor before you say it is encased by the tumor. Either you tell us about the arterial anatomy and then tell us about the tumor and involvement of the vessel, or you show the tumor and then describe the arteries.
This is the site of tumor, sir.
Okay.
And this is right hepatic artery, sir.
Okay.
And this still looks like possibility of tumor extensions at this.
No, I don't see any tumor there. Where is the tumor?
This is
That is probably tumor, because see, what you have to see is, you see the ducts. Ducts are black in color. So you're expecting something inside the ducts. If there's a hypodense area within the tumor, we know it's a mass forming lesion according to the ultrasound. So you should see that. So try and point out where the tumor is.
This whole thing appears to be.
Okay. But you'll probably see it well on a venous phase, but you can just see if the artery is in proximity and whether it is involved or not. And you should make a comment on the arterial anatomy also, whether it is classical, whether there's a replaced artery, where is the segment 4 artery coming from. All right, all that you have to mention.
Classic and normal anatomies, no variations.
Yeah, you just trace the right and left.
It is coming
Show the
on
segment
the
4
left.
artery.
Yes, sir.
Can you show the segment 4 artery?
Probably so this one.
You can see the portal vein. You can see in the fissure on the right of the portal vein is segment 4 artery. There, you have to trace it back. Yeah, that's probably segment 4 artery. I would agree. Yeah, that's the origin of the segment 4 artery. Okay. Yeah, you want to see the portal place? You show where the tumor is?
So this is the site of tumor.
Come down a bit more. Come down. Come down some more.
Right portal
Going too fast,
vein
but
caliber appears to be normal, sir. Yes,
right,
sir.
that's fine. But you can see
And
the dilatation on both sides.
yes, sir.
Okay, and see where the right duct seemed to be cut off. You saw on the MR, anterior and posterior were totally separated. So just stop here. Just come down once. Yeah, stop here. So if you stop here. See here, you're not seeing any right anterior duct in this section. You can see the right posterior duct is away and
Yes.
left is nicely dilated. Segment 4 is dilated. You can see the caudate duct is also dilated. Can you see that?
Yes, sir.
That's the caudate duct. So probably that is the area of the mass lesion and it's causing separation of the right side. Okay.
Yes.
All right.
And left side it is segment 4 duct and 2-3 ducts are forming the things.
Yeah. Possibly that is 4, but we have to see properly. That is a little bit to the left.
Yes. And no other any
It's more
space
on this
occupying
side.
lesion.
Yeah. You
Is
go
it?
up a little bit, you'll see the 4 there. Okay,
There
so
is no
that's
any other
fine.
space occupying lesions in the
The
liver.
interpretation of dynamic
And
CT
regional
images
nodes.
yeah, it will take some time. You have to spend some time in the console with the radiologist, and you have to sit and see it properly. You have to see the arterial and portal vein images side by side for surgical planning. So in this sort of online format, we can't dwell too much on it, but grossly, what have you found from the CT, and what information you need from the CT, you tell in 1 or 2 minutes. You tell. So what is your analysis after the CT?
There is a hilar mass, which is involving hilum, extending into the right secondary confluence and not extending into the left secondary confluence. And it is probably involving right hepatic artery, but not causing any infiltration to the portal venous system, sir. And without any evidence of liver mets or any cholangitic abscesses or significant regional lymphadenopathy, I couldn't able to see, sir. And no evidence of pulmonary or any abdominal mets.
Okay, very good.
The
Okay.
section where sir was teaching, in that there was non-opacification of right portal vein also, na? But more important is what you want to look at and what you expect to be normal, what you want to ensure that these things are normal, so you can decide the plan. What are those things which you want to look at? And you want them to be normal, not involved by the mass.
In
These
this
things
case,
are involved by mass, I agree. What things you want to ensure that these things are not involved by the tumor, so that you are happy for the patient.
yes, I want to look like what is the status of right and left hepatic arteries and right and left branches of portal vein. And what is the extension of lesion onto the left side? It is encasing the right, it is involving the right secondary confluence. What about left secondary confluence?
Okay, that is about biliary radicals.
Yes.
In other words, what are the criteria of inoperability? When you call this patient as inoperable, those things you don't want, or you will want to ensure that these are not there.
Yes, ma'am. If the ipsilateral mass is involving ipsilateral
About
mass.
vascular structures,
Yes,
about biliary structures, you have said that secondary biliary radicals on the left side are not involved. Okay, you are happy. Next thing.
Ipsilateral involvement of right hepatic artery and contralateral involvement of left portal vein, or vice versa, ma'am. And contralateral involvement of right hepatic artery and contralateral involvement of artery and portal vein, ma'am.
Okay. So the things which decide this lesion is inoperable, you have to look at the common hepatic artery.
Yes, ma'am.
Right? If common hepatic artery is involved, straightway it will become inoperable.
Yes, ma'am.
In normal scenario, not without any under trial. So, and lobar atrophy. Okay, and if the main portal vein is involved, then it becomes inoperable.
Yes, ma'am.
Sure.
Yes, ma'am.
You cannot resect the main portal vein.
No, in biliary malignancy, I'm not sure.
Okay. So as of now, it depends on the extent of main portal vein involvement. But if it is involving the main portal vein near the hilum and extending on the right side, then you can resect the main portal vein and reconstruct the left portal vein with a graft or after mobilization of the main portal vein. So portal vein involvement is not criteria for inoperability, but artery is yes. Okay, so basically you have to look at the common hepatic artery, left hepatic artery. These have to be patent, and there should not be any lobar atrophy and metastasis in trihepatic and extrahepatic, right? What about the lymph nodes? Which lymph nodes?
Regional
You want
lymph
to
nodes
look.
were not enlarged, ma'am. Portal
Okay.
lymph nodes were not significantly enlarged.
Okay. And if they are enlarged, then
If there is without any history of recent cholangitis, I would probably think of regional lymph node metastasis.
history of cholangitis, then what did you say?
Without any history of cholangitis in this patient, I would probably think of
Okay.
possibility, ma'am.
Okay, but that doesn't become a criteria for inoperability, right?
Yes, ma'am. It is not
Okay.
an
Okay. So now what is the interpretation? What is the final thing comes to your mind after looking at the CT and MR?
ma'am, I want to look CT report once.
Anything else you want to do you want to think about the CT? Now you
I
have
didn't
looked
get
at
the
the
question.
CT, you are thinking that the right side structures are involved, left side structures are free. So next step, you are going to plan a surgery, and for that you will again looking at CT for something.
Oh, volumetry, ma'am. At the same
Yes.
volume of
So,
the future liver remnant.
okay. So that information also you will get on CT. Okay.
Dr. Harish, all these are very, very important points which Madam has said.
So which
Um,
liver volumes you want? What will you ask your radiologist to give you, or you will go and calculate?
Yes, ma'am. I want to see the segment 2, segment 3, and segment 4, ma'am. What is the contribution of segment 2 and 3 alone? And if segment 4 is added,
For that, again, you have to tell me what surgery you are thinking of. So the remnant you are thinking of.
yes,
You are thinking of which
right
surgery?
trisection.
Madam, if I
Right
may,
trisection.
before that, we'll have to solve two things. One, are you going to, I'll ask a direct question because we have about 10, 12 minutes. So I want to cover a couple of things. So I'll ask you a direct question. Would you make any efforts to establish the diagnosis on biopsy or not? If so, how? And what are the pros and cons of various methods of establishing a diagnosis with biopsy in this patient? Number one. Number two, before surgery, obviously, will you do a biliary drainage or not?
Yes.
And how would you do it? So answer this to the point, and then we can go to the volumetry.
Yes. In this patient, I'm not sure of any. I'm still not sure of malignancy. I want to get biopsy done, sir.
How
Like
would you
once I want to look for what is the CT report, sir.
No,
Is it
CT report is
mandatory
what you
always?
said. Don't worry about the CT report. It is what you said. Okay.
Yes.
So we agree. The radiologists have told the same thing.
Yes, sir. It is not mandatory to get this sensor biopsy, sir.
All right. So
But in this case, if you want, how will you take?
In this case, percutaneous biopsy I will get.
Percutaneous. You want to give
There is
reconsider it.
There is 5 into 4 centimeter mass. So
what do you plan to do for the jaundice? Bilirubin is 20.
yes,
You're planning
yeah,
a major hepatectomy. What would you do?
there is involvement of pectoral depths also. So I would like to get this one, sir. Percutaneous PTBD in these patients.
Which side?
Sir, I want to drain future liver remnant also.
Which
And
is?
left side.
Also, you mean you'll drain both sides, one side? What would you
Both,
do?
sir, both sides I will drain, sir.
Why not only left side?
Sir, it may take the bilirubin levels to the normal level, sir, but still there is a possibility of patient going into cholangitis. So I'd like to drain the lobes, both the lobes.
Dr. Harish, I would disagree with you. See, the right system is totally separated, right? Anterior, posterior is separated. And if you unnecessarily put a tube on that side. And if there is cholangitis, it will be a problem. It will delay your surgery. And left side, I think if you're planning a right-sided resection, draining only the future liver remnant generally takes care of it. If it doesn't work, if the jaundice doesn't come down after a few weeks, you can always put in a PTBD on the right side. In experience centers, you can do a ERC also. It is not a contraindication. You can do ERC and stent the left side. Although I agree that since the right systems are separated, if dye goes on the right side, there is a possibility of cholangitis. And I mean, percutaneous biopsy, why? I mean, why not do a ERC brushings, things like that.
ERC brushings yield is less. There is a mass. If there was no mass forming thing, I would have get this ERC
So
brush.
it's the intraductal mass, isn't it? So if you do a ERC and biopsy it, what is the advantage of doing a biopsy and what is the problem of doing a biopsy?
It is near the major vascular structures of hilum, so that is the risk, sir.
So the risk is more with
Deep-seated.
percutaneous, isn't it then?
Yes, sir.
And plus with a dilated system, you're likely to hit some dilated system, there's a bile leak if you do a percutaneous biopsy. Also the theoretical risk of tumor seeding. So all reasons not to do a percutaneous biopsy. In ERC, you have a mass forming lesion, the yield will be high. You can always do a ERC with some, biopsy, and you can do a rapid on-site evaluation. So that will increase your sensitivity. And the plus point of a biopsy is it is highly specific. So if it is very specific, the false positive will be less, but still there is a significant false negative rate, which you can circumvent by various methods to increase the sensitivity of your test. So you should be precise in your answer. So I would think that percutaneous biopsy may not be a good idea. You can even consider a US guided biopsy. Sometimes through the stomach, the hilum may be accessible in experienced centers, or ERC brushing with left-sided stenting, all that you can plan. All right, so in this case, I would not say that you will not establish a diagnosis because it's a 27-year-old person, very atypical presentation. I would go all out to establish a diagnosis because the morbidity of surgery is significant. So you want to be sure you're dealing with a malignancy. All right. And I think volumetry data we can show. Madam was asking, please show the volumetry data. See, they have done a biopsy. It's suggestive of adenocarcinoma. All right. And volumetry data, we can have a look. So based on this, what is your surgical plan? You can tell us.
So just to be clear, Sir Harish, what are the absolute indications of biopsy? One is this: when there is no diagnostic, when there is no proper diagnosis and there is dilemma in spite of all investigations, like in this case, patient is young and all. So okay, biopsy. What is the another only indication you can say for biopsy?
If we are planning, if it is unresectable biopsy.
Very good. So if you want to plan a neoadjuvant chemo or chemoradiotherapy, right? Otherwise, the biopsies, preoperative diagnosis is not mandatory. And if at all you want to take, you have to take ERCP with breast cytology or EUS guided, but to avoid a percutaneous. Okay. Go ahead with volumetric.
Left lateral segment, 29%.
Okay, so just be quick. What you are looking at?
Left lateral segment.
Which volume you are looking? Yes, good.
Left lateral segment is 30%, ma'am, with normal liver parenchyma, normal liver.
So you should mention your surgical plan first, yes, and then interpret the volumetry.
I would plan right trisection.
Right trisectionectomy. What things come in that, and you want to add something, or that is the final surgery you want to do?
With chordate lobectomy. And so it includes segment 5, 6, 8, 7 and 8, and 4A, 4B, and segment 1.
Okay, why chordate? These are the standard questions and standard answers.
Chordate has drainage into the hilum from right and left duct. So it is probably involved by the tumor. Tumor seeding will be there in that lobe, and that's why.
Okay. So chordate lobe resection is
staging laparoscopy, and then these things. So it's 8:55. So the session is till 9 or 9:15, sir? Pradeep, sir?
Right. You can go until the discussion. There's no problem. 9:15 is
Okay.
not. Go
Okay.
ahead.
All right. So you should say staging laparoscopy and right hepatectomy or hepatectomy extended onto 4 with caudate, definitely caudate excision. All right. So that will be your surgical plan. So can you briefly tell the steps of surgery?
Yes. After induction, I would like to do staging laparoscopy first, and I will roll out the metastasis, any liver lesions, and any free fluid, and any peritoneal deposits. After it, I would like to give abdominal incision. I will plan for open procedure. So I would like to give bilateral subcostal incision. After that, I will assess the resectability first, sir. Is it resectable involving any structures? And still, I would like to do bilateral liver palpation for any possibility of mets also, sir.
See, that is a very
So
crude way of doing it.
after
If you
making
want, you
sure
can
that
do an
there is no
intraop
metastasis,
ultrasound. You know,
sir.
if you want, you can do an intraop ultrasound, but you can't assess deep intrahepatic mets with palpation. And even anyway, you've done some good imaging, isn't it? And in Hilar cholangio, it's unlikely that that you'll find something unusual. But yeah, you can always do a intraop ultrasound as part of your staging laparoscopy if you want. So how will you assess this local resectability?
Yes, sir. Like, what is the status of main portal vein and proper hepatic artery and its branches, sir?
So you should, how will you, what will you do in the sense, instead of asking questions, you say that what all structures
And
you deal
if
in
there is,
intraop. So
yes,
where will you
if
start your
it's
dissection?
in the hilum, sir, if there is
Okay.
any doubtful at any of the steps about regarding the involvement, intraoperatively, I would like to get ultrasound done with the help of radiologist, sir.
That may not help for the hilum. You have to define the hilar structures and what will you do?
Yes.
Essentially, what will you do first before saying this is resectable or unresectable?
Hilar dissection, sir.
What
And
will
what
you
is
do in
the
the hilar
extent?
dissection?
Yes, sir. I would like to separate the left portal vein and main
Very
portal
good.
vein and left hepatic artery
Very
and
good.
proper hepatic arteries.
Right. So you want to see if your future liver remnant is going to be segment 2, 3, and 4, or at least most of 4. So you should dissect out the left hepatic artery. It's easy to dissect out the left hepatic artery first because it is away from the hilum usually. So you make sure
Yes.
that the left hepatic artery is not involved in the tumor. You also saw the origin of the segment 4 artery, where it was from. You see if it is involved in tumor or not. You separate out the arteries. Then you loop the left portal vein and you see the main portal vein. So if left portal vein is free and left arteries are free, you know that you will be able to do the resection safely because it's a hilar mass. Once your inflow to your remnant is okay, you're okay to proceed with the surgery safely. Many times in this sort of situation, it's not unusual to find that the main portal vein is involved, like Madam was saying. So it is not a contraindication in biliary malignancy, especially hilar cholangiocarcinoma, to resect a segment of the portal vein and anastomose it. So you can do it at the first step and before you proceed with the rest of the resection. So once you are sure that your inflow to your left structures are okay, what will you do next?
After getting the inflow control, I would like first do mobilization and take the outflow controls. That is, I will loop right hepatic vein, middle hepatic vein, and left hepatic vein separately, sir.
Here the remnant is on the left side. So you loop the left and middle together. All right. So that is your outflow here. You understand? So you will mobilize the left lobe. You can loop the left and middle veins together. It's not mandatory to do it at this stage also because there's no tumor anywhere near it. Okay, fine. You got outflow control. You don't have to mobilize the liver at this stage. But if you want, you can do it. But before the transaction, you have to mobilize it. Okay. After that, what will you do?
As I'm planning,
You've got the outflow and inflow sorted out. Then?
after taking in outer control, now I will start my parenchymal dissections.
No. Before that, see, you have to divide the bile duct, isn't it? So you can divide the lower end of the bile duct, send the lower end for frozen. So if there is no malignancy there, then you can reflect the bile duct upwards. Then your portal vein and right-sided structures will become visible. And the point where the tumor is at the bifurcation, you will see from behind. And you will see that it is involving the right structures. You can stop there. So you can divide the bile duct. Once you are sure that it is resectable, and once you're sure you'll be able to resect it, then you can divide the bile duct. Then it will make your job a lot more easier. And then you can do a little bit of parenchymal transaction, finish the hilum, and then do it. All right. So, I mean, it's a difficult surgery. It is not something that we will be doing very often, but it has to be done safely. So you should know the steps. And you may or may not be asked in the exam, but you should know it. All right.
So what about the margins?
Sir, ma'am?
Margins. Which margins you will look at, and what will be the duct margin you want? Sir said about
Yes,
distal CBD margins ending for frozen, right? So what are the other margins you are looking at?
the main
Or you will
intention
look
is
at?
on the left system margin, ma'am.
Okay, ductal margin. You mean the proximal ductal margin?
Yes, ma'am. Left ductal margin.
Okay. How much you want it? How much you want it to be free?
5 to 10 mm. Gross.
5 mm and 10 mm is a huge long distance in case of
5 mm.
So how you will answer? You will send the for frozen.
Yes, ma'am.
You want to send the margin for frozen?
Yes, ma'am. I will send it for
Is it
frozen.
possible to
operation
revise?
will be doing it?
Is it possible to revise?
What stage of the operation will you be sending that biopsy of the left duct? That's what madam is asking.
In the initial stage only, so while cutting this thing, bile duct, then I will send for frozen. Sorry, sir.
No,
Usually the distal bile duct, distal CBD is cut in the initial stage of the surgery, but the left hepatic duct will be cut at the end of the surgery.
All right. See, when the specimen is coming out, only then you will cut the left hepatic duct. How can you cut the left hepatic duct?
That's in the last step of the surgery.
Or the other way to do it is you can finish at least the lower part of the transaction. If you finish more than 1/3 or so, then you can loop the left duct and cut it. But you will not be able to do it in the initial part of the operation. And you have to make an intra-op judgment. You know, you have to feel and see where the tumor is, and wherever you feel it is supple, you will cut it, and then you can send a margin from the remnant side. But you have to remember that there are practical considerations here. You can only do so much. The extrahepatic part of the left duct is long, so you can get a good margin. But you know, if it comes as R1, in the sense if they find it as malignancy, you can cut only a little bit. You can't go too much into the liver. You know, you can do separate anastomosis between 4 and 2-3. So generally you should get a negative margin. But if you're getting positive and you can't go anymore, you have to accept it. But on the left side, more or less, you'll get a negative margin. So when you have to cut at the end of the operation. All right. I think I have no further questions. Madam, you finish, and then we'll leave it to the experts to make some comments. Thank you.
You want to ask anything? You want to ask anything?
Hello, ma'am.
Yeah. Have you finished? Go ahead, Sharvari. Go ahead. No problem.
Yes. I wanted to just add one more thing. If the liver remnant would be less than 30%, then one more important step will come in the surgery. Okay. In this case, it is 30%. What is that? We'll think about. If the FLR is less.
Augmentation. FLR augmentation procedures. Portal vein embolization.
Okay. But in this case, the portal vein was already involved, right? Right portal vein was involved. Yes. So that got beneficial. It was beneficial for the patient in the form of
Augmentation of left lobe.
Yes. So sir was saying something. Pradeep sir.
No. If you have finished, we can go for the.
Yes, sir.
Yeah, we have Dr. Supe, Dr. Shastri, and Dr. Kapoor.
Morning. Good morning, Pradeep.
Morning, sir.
So some general comments and then some specific comments about this case. 27-year-old male, 1 month history of painless progressive jaundice. You made a diagnosis based on this history of primary sclerosing cholangitis. I personally do not prefer that students make a radiological or a histological diagnosis based on history or examination only. See, diagnoses like primary sclerosing cholangitis, cystic pancreatic neoplasm, xanthogranulomatous cholecystitis, these are not clinical diagnoses. They are findings on radiology or histopathology. And students have to remember it's not necessary that in every case you have to make a diagnosis based on history. If it is not possible to make a diagnosis, you interpret it. So if I were you, I would have said that this is surgical obstructive jaundice, most probably benign. The commonest cause of benign surgical obstructive jaundice, or for that matter, any surgical obstructive jaundice, is CBD stone. But this is unlikely to be CBD stone because there is no history of pain. The next common cause of benign surgical obstructive jaundice is choledochal cyst, which it is possible. Although the classical history is repeated episodes of jaundice, pain, and cholangitis, but it could be a single episode. Then you should have said that since this is painless progressive jaundice, it does look like and a short duration, it does look like malignancy, but he's too young for malignancy, 27-year-old. The only the possibility in painless progressive jaundice, as Dr. Sharvari was trying to tell you, are periampullary carcinoma and hilar cholangiocarcinoma. Now, a periampullary carcinoma in a very young patient is possible if there is associated polyposis. But there is no history of GI bleed in this case. So in the negative history, once you knew that you are going to discuss a possibility of a periampullary, you should have emphasized there is no history of bleeding per rectum, fresh blood, or melena. That should have been emphasized so that the examiner knows that you are thinking of this possible combination. At the same time, the student should remember that uncommon presentation of a common disease is more likely than an uncommon presentation of an uncommon disease. So I would say that a painless progressive jaundice, it is uncommon presentation of CBD stone, but it can happen. If the stone is impacted, you can have painless progressive jaundice. And as I said, CTC is a possibility. Next, I would come to specific points in two more general points. This differentiation between periampullary and pancreatic head cancer, unfortunately, many textbooks, some articles also, and probably some examiners do not differentiate between them. But I agree with Sharvari that we should differentiate between them. Periampullary cancers is a group of cancers involving the ampulla. It is a 2 centimeter around the ampulla, not the papilla. Ampulla is the common channel formed by the distal common bile duct and terminal part of the pancreatic duct. The ampulla then opens on the papilla with the nipple-like projection on the medial wall of the second part of duodenum. So what you see on side-viewing endoscopy is papilla, not the ampulla. And in periampullary cancers, waxing and waning, although mentioned in most textbooks, is not commonly seen. But if at all it is seen, it will be seen in a papillary tumor or in a peripapillary duodenal tumor. It will not be there in an ampullary carcinoma, in a distal cholangiocarcinoma. And that is characterized by melena and some decrease in jaundice, which comes back again. Now, the biliary confluence on the left side, the left secondary biliary confluence is where segment 4 joins the common channel of 2 and 3. So in every cholangiogram, in every imaging, you have to see that where is the segment 4 duct joining? Is it joining close to the hilum, the primary confluence, where it is likely to be involved by the tumor? Or is it joining away from the primary confluence, more close to the 2 and 3 junction? That is important because that decides the extent of liver resection for a hilar cholangio. If segment 4 duct is far from the hilum and it is free, it is also dilated, you see a a normal dilated left hepatic duct distal to joining of segment 4, then the right hepatectomy alone is good enough. On the other hand, if segment 4 duct is close to hilum or is definitely involved, then you may have to do an extended right hepatectomy even for a hilar cholangiocarcinoma. In this particular case, I thought that the right portal vein, although it was seen, but its shape was altered. So I thought it was involved, and I also thought that there is some hypertrophy. There's no atrophy of right lobe, but there is some hypertrophy of the left lobe, which probably is documented on volume also, because both the lobes had 50% volume, which is not the usual distribution. At one stage, you said I would look for involvement of the right hepatic artery and right portal vein. That is not the correct answer. Right ductal system is involved. Right hepatectomy has to be done. So whether right hepatic artery and right portal vein are involved or not is immaterial. What is important is involved, as Sharvari pointed out, involvement of the main portal vein, the proper hepatic artery, and the left vessels. If the left vessels are involved, then this may become a contraindication for surgery, although involvement of the main vessels is not a contraindication, as opposed to gallbladder cancer, where it has now been established that there is no role of vascular resection. In cholangiocarcinoma, because of its different biology, there is still a role of vascular resection, especially portal venous resection. Most groups would not go on to do arterial resection, although some still do, but portal vein resection is done as a routine. Next was biopsy. I think your answer was grossly wrong, unacceptable. Your answer should have been that if the lesion is resectable and if the patient is fit for surgery, biopsy is not mandatory. But since he is a very young patient, 27, I would still like to establish that this is malignancy before I proceed with resection, although the images strongly suggest a diagnosis of malignancy. And the methods of obtaining biopsy, percutaneous is not. Percutaneous is not in fact, it is contraindicated if you are thinking of resection in any of HPB malignancies. You should have said it is endoscopy, side-viewing endoscopy, bile cytology, breast cytology. You should have talked of endoscopic ultrasound-guided FNAC. You should have even mentioned cholangioscopy and a direct visualization of the tumor and biopsy. Next was preoperative biliary drainage. Even in hilar block, because you want to drain, and before that, you have to drain the FLR. The only indication of bilateral drainage to begin with is uncontrolled cholangitis. If that is not there and the indication is to bring the bilirubin down, then it is always the segment which is to be retained, in this case, the left lobe, which has to be drained. So since this was a hilar block, which is mainly going to left side, right side, as Kishore said, an expert endoscopist can easily place a stent in the left duct, and that serves the purpose. So first choice would be an attempt at endoscopic drainage. If that is not successful, then a percutaneous biliary drainage, but of the left side first. If the bilirubin doesn't fall to below 3 or to normal with left side drainage after adequate time, then becomes an indication for right side drainage. And when you describe the operation for a hilar cholangiocarcinoma, here it is a hilar cholangiocarcinoma involving the right ductal system. Left duct is free, segment 4 duct is free. So the procedure is hepatectomy. I don't know why you said extended right or a right trisectionectomy, because to me on the image, it doesn't appear that segment 4 duct is involved. And for hilar cholangiocarcinoma, you always have to say hepatectomy with caudate lobe and lymphadenectomy. So that is the complete description, and you can't mention the operative procedure for a hilar cholangiocarcinoma without, on your own, not on prompt by the examiner, mentioning frozen section of especially the left ductal margin. Here the tumor is at hilum, so lower margin is not that important, although yes, you will get it done, but most important is the left duct margin. And as Kishore was saying, that left duct usually has a long extrahepatic course. So if the margin comes positive, you can resect some more and send again for frozen section. If it goes up to the segment 4 duct, then you will have to think of an extended right hepatectomy. So students, please send me a mail, vkkapoor.india@gmail.com. I'll send you the chapter on SOJ malignant gallbladder, which also includes some discussion about cholangiocarcinoma. Thank you.
Any comments from Tatsupe? Shastri?
Nothing much, except nothing by and large, the topic is very well covered. And Harish has done fairly well. The only objection is to the choice of his percutaneous biopsy. That is definitely not acceptable. I think otherwise, most of the comments are already made by Dr. Kapoor.
Yeah, I think he has done reasonably well. If there are no other comments from the faculty, can we wind up, Kishore and Sharvari?
Yes, sir. Thank you, Harish. Thank you, sir.
Yes, sir.
Thank you, Harish.
very
Thank you,
much.
Sharvari. Thank you, Kishore.
Thank you, ma'am. Thank you, sir.